Ever caught a glimpse of someone's lips, or maybe their fingertips looking a little, well, bluish, and wondered what was behind that subtle color change?
Hmm.
Today on the Deep Dive, we're tackling that very question. We're plunging into the topic of cyanosis, that bluish discoloration of the skin and mucous membranes.
Yeah, it might seem pretty straightforward, just a color change, but there's actually a fascinating story behind it.
Absolutely. And our mission for you today, the learner, is to really cut through the medical jargon.
Right.
We want to understand the core of what cyanosis signifies, what some of the key reasons behind it are, and why noticing this bluish tint could be such an important signal in different health situations.
Exactly. We'll be drawing on some detailed medical information naturally, but our focus is definitely going to be on clarity and hitting those crucial aha moments for you.
Think of this as your express route to understanding something that might otherwise feel quite technical.
Yeah, definitely.
And just to get us oriented, it's helpful to know right off the bat that there are two main categories, sort of types,
Mm-hmm.
of cyanosis. There's central, which affects the whole body, and peripheral, which is more localized, like in the fingers or toes.
And we'll definitely explore both of those in more detail.
Okay, so let's get right to the heart of it.
Yeah.
Beyond just being a visual cue, what exactly is cyanosis, fundamentally?
Well, at its most basic level, cyanosis is that bluish discoloration you see. But the underlying cause, the mechanism, is an increased amount of deoxygenated hemoglobin in your blood.
Hemoglobin, that's the protein in red blood cells carrying the oxygen, right?
Precisely. It's an oxygen transporter. So
Yep.
basically, more blue color means less oxygen is being carried effectively by that hemoglobin.
Okay, so a higher level of this deoxygenated hemoglobin points to some kind of problem with oxygen delivery. Is there a specific point, a tipping point, where we actually see this blue color?
Yes, and this is a really crucial point. That bluish tint, it only becomes visible when the concentration of deoxygenated hemoglobin in the blood goes above 5 grams per deciliter.
5 grams per deciliter, okay.
That's the critical threshold our eyes can actually pick up. So, even if oxygen levels are somewhat low, you might not necessarily look blue until you cross that specific concentration.
Right, 5 GDL, the magic number.
Hmm.
So if someone has low oxygen in their blood, they should look bluish once they cross that line. This seems logical.
Well, not always. And this is a really key insight, something important to remember. You can't rely solely on the absence of blue to rule out low oxygen.
Oh, how so?
Okay, imagine someone with anemia. They have a lower than normal number of red blood cells, right?
Right, less hemoglobin overall.
Exactly. So they might have a low overall oxygen level in their blood, but because they have less total hemoglobin to begin with, even if a high percentage of it is deoxygenated, the actual concentration, that 5-GDL number, might not be reached.
Ah, I see. So the total amount of deoxygenated hemoglobin might still be below the visible threshold, even if things aren't great oxygen-wise.
Precisely. Their lower baseline carrying capacity can essentially mask the lack of oxygen visually. It's a potential pitfall in assessment.
That's a really important distinction.
Okay.
So let's get into the specifics of those two main types you mentioned, central and peripheral. What's the key difference with central cyanosis?
So central cyanosis affects the entire body, lips, tongue, trunk, everywhere. And it typically indicates a problem either with the oxygen levels in the arterial blood itself.
That's the oxygenated blood going out to the body.
Exactly, the blood leaving the heart. Or sometimes it's an issue with the hemoglobin molecule itself, like that methemoglobinemia we'll touch on. Think of central cyanosis as a systemic, a body-wide issue affecting oxygen delivery to all tissues.
Okay, whole body arterial blood problems, or maybe hemoglobin issues. Got it. What are some of the main things that can cause this body-wide oxygen deficit? The source mentioned arterial hypoxemia. What's the gist of that?
Arterial hypoxemia, it simply means there's a lower than normal level of oxygen, specifically in the arterial blood. And this can happen for several reasons where oxygen just isn't effectively getting into the bloodstream in the first place.
Okay, like what?
Well, think about being at a high altitude. That's a really common example.
Right, less oxygen in the air.
Exactly. There's just less oxygen available in the air you inhale, which naturally leads to less oxygen getting into your blood. Simple physics, really.
Okay, thinner air, less oxygen gets in. Makes sense. What are some other common situations that lead to this low arterial oxygen?
Another frequent cause is something called hypoventilation. That's basically when you're not breathing deeply enough or frequently enough.
Okay, underbreathing.
Yeah, and this can happen in lots of situations. Maybe your upper airway is obstructed, even a bad cold or choking on something could potentially do it. Or it could be lung diseases that restrict your ability to breathe fully, like, say, severe asthma or certain chronic lung conditions.
So if you're not moving enough air in and out, the blood doesn't get properly oxygenated.
That's the bottom line. Not enough ventilation, lower oxygen levels.
What about issues within the lungs themselves? I remember seeing the term ventilation-perfusion mismatching.
Yeah.
That sounds complex. What's the core idea there?
Okay, think of your lungs like this. They have millions of tiny air sacs, the alveoli, right?
Yep.
And for oxygen to get into the blood effectively, these sacs need a good supply of both air, that's ventilation, and blood flow passing by them, that's perfusion.
Air meets blood.
Right. Now, if there's a mismatch, say some air sacs are getting plenty of air, they're well ventilated, but the blood flow to those specific sacs is poor, maybe because of a blood clot in a small lung artery, for instance,
Right.
then the oxygen in that air can't be efficiently picked up by the blood. It's like having delivery trucks, the ventilation, arriving at a warehouse, the air sacs, but there aren't enough workers, the blood flow to load the goods, the oxygen.
Gotcha. An imbalance between the air supply and the blood supply in parts of the lung. And then there was another one mentioned, diffusion impairment. What's that about?
Okay, so imagine that very thin membrane separating the air in the air sacs from the blood in the tiny capillaries surrounding them.
The barrier oxygen has to cross.
Exactly. Oxygen needs to diffuse, to pass across this barrier to get into the blood. Now, if this membrane becomes thickened or damaged perhaps from scar tissue in chronic lung diseases or inflammation,
Right.
it makes it physically harder for oxygen to make that jump across efficiently.
Mhm.
So even if you have good airflow, good ventilation, and good blood flow, perfusion, the actual transfer of oxygen itself is hindered.
Okay, so a thicker or damaged barrier slows down the oxygen transfer. Makes sense. Now, the source also mentioned right-to-left cardiac shunts. That sounds like a heart problem causing this systemic central cyanosis. What's going on there?
Exactly. These are often congenital heart defects, meaning they're present right from birth.
Okay.
Normally, deoxygenated blood comes back to the right side of the heart, gets pumped to the lungs to pick up oxygen, comes back to the left side, and then gets pumped out to the body.
The standard route.
Right. In a right-to-left shunt, there's an abnormal connection, like a hole or misplaced vessel, that allows some of that deoxygenated blood from the right side to bypass the lungs entirely and go directly into the left side or the aorta, mixing with the oxygenated blood.
Oh, so it takes a shortcut.
It takes a shortcut, exactly. Conditions like tetralogy of Fallot are classic examples you might have heard of. The key thing is unoxygenated blood is mixing with oxygenated blood before it even leaves the heart, lowering the overall oxygen level going to the entire body.
That would definitely do it. Sending out partially deoxygenated blood system-wide. And the source also mentions something called reversed shunting due to high pressure in the lungs. How does that work?
Yeah, this is a really fascinating consequence that can develop over time with certain other heart defects. Sometimes you might have a defect like a patent ductus arteriosus, a PDA, or holes between the heart chambers, an ASD or VSD. Initially, the pressure might be higher on the left side, so some oxygenated blood leaks back towards the lungs, a left-to-right shunt. But, and here's the twist, over time, this extra blood flow to the lungs can cause the blood vessels there to thicken and stiffen. Pulmonary hypertension develops.
Ah, the lung pressure goes way up.
Way up. Eventually, this pressure in the pulmonary artery can become so high that it actually exceeds the pressure on the left side of the heart. And when that happens, the blood flow through that original defect reverses.
It flips.
It flips. Now blood flows from the right side, the deoxygenated side, through the defect to the left side or into the aorta. This is called Eisenmenger physiology. And again, you're sending deoxygenated blood out to the body, causing central cyanosis.
Wow, that's incredible. The body's own reaction to the initial problem ends up reversing the flow and causing a different problem.
It's a complex adaptation, unfortunately with negative consequences. And the source rightly noted, certain dog breeds, Keeshondan, English bulldogs, beagles, and some cats seem more predisposed to the underlying defects that can lead to this, often seen in younger animals.
Right, a good reminder, this isn't just a human thing. Now, what about anatomic shunts? It mentioned they're special because giving extra oxygen doesn't help. Why is that the case?
Yeah, anatomic shunts are a specific, less common type of right-to-left shunt. These are basically direct abnormal connections between arteries and veins, often within the lungs themselves, that completely bypass the capillaries where the oxygen exchange is supposed to happen.
So the blood literally detours around the entire oxygenation area.
Exactly. Because the blood is taking this shortcut, completely bypassing the air sacs, increasing the amount of oxygen the person or animal breathes in doesn't actually help oxygenate that shunted blood. It never gets near the extra oxygen.
Ah, okay. It's like adding more lanes to a highway exit doesn't help the traffic that's taking a completely different road miles back.
That's a great analogy. It really highlights how different underlying mechanisms, different plumbing problems, if you will, can all lead to that same visible sign cyanosis.
Definitely. Now, shifting gears slightly, the other main cause of central cyanosis mentioned was abnormal hemoglobin, specifically something called methemoglobinemia. What's the core issue with this methemoglobin?
Okay, so methemoglobin is basically an altered form of normal hemoglobin. It's hemoglobin where the iron component is in a different chemical state, the ferric state, instead of the usual ferrous state.
And what does that change mean functionally?
It means it can't bind and carry oxygen effectively. Think of it as a faulty oxygen transport truck.
Okay, so some of your sleet is out of commission.
Exactly. Normally, our red blood cells have enzyme systems, primarily one involving an enzyme called NADH cytochrome bifiber reductase, or NADH-MR for short, that constantly work to keep the level of methemoglobin very low, usually less than 2% of the total hemoglobin.
So we have a built-in repair system.
We do. But if this enzyme system is deficient, which can happen due to a rare inherited condition seen sometimes in dogs, for example,
Okay.
or much more commonly, if someone is exposed to certain oxidizing drugs or chemicals, these substances can overwhelm the enzyme system and cause the levels of methemoglobin to shoot up.
And what kind of common things act as these oxidizing agents? What should people be aware of?
Well, there's quite a list. A common one, especially relevant in accidental ingestions or overdoses, is acetaminophen Tylenol.
Really, acetaminophen.
Yes, particularly in cats who are very susceptible, but also in dogs and humans at high doses. Others include nitrates and nitrites, which might be found in certain fertilizers, contaminated well water, or some preserved foods, certain topical anesthetics like benzocaine, and some industrial chemicals and dyes can also cause it.
Okay, that's a pretty varied list.
It is. And if the methemoglobin level in the blood rises significantly, typically getting into the 20 to 40% range or higher, it severely reduces the blood's oxygen carrying capacity. This leads to tissue hypoxia, low oxygen in the tissues, and that characteristic central cyanosis. Sometimes the blood itself even looks chocolate brown.
Wow, okay, so that gives us a good picture of central cyanosis, either not enough oxygen getting into the blood or the blood itself can't carry the oxygen properly. Now, how does peripheral cyanosis differ from this?
Peripheral cyanosis, unlike central, is localized. You typically see it in the extremities, fingers, toes, maybe the tip of the nose or earlobes.
So not the tongue or inside the mouth like central.
Generally, no. The key difference is the cause. It's usually due to a reduction in blood flow to those specific areas. The blood moves more sluggishly through those peripheral tissues.
Okay, slow blood flow in the limbs. Why does that cause the blue color?
Because the blood is moving slower, the tissues in that area have more time to extract oxygen from it. So by the time the blood gets into the small veins leaving the area, it has a much higher concentration of deoxygenated hemoglobin compared to normal. And that's what gives those specific extremities the bluish hue. The problem isn't necessarily the oxygen level leaving the heart. It's the slow flow allowing more oxygen to be pulled out locally.
Ah, I get it. The oxygen is being used up more thoroughly in that specific spot because the delivery is slow. Makes sense.
Precisely.
So what kind of things cause this reduced local blood flow?
Well, a really common cause is severe vasoconstriction, the narrowing of blood vessels. This happens often in response to cold temperatures, right? Your fingers might turn bluish in the cold.
Yeah, definitely seen that.
Poor overall circulation, like in some types of heart failure or shock, can also contribute. Or there could be a physical blockage in the arteries supplying the limb, like an arterial thromboembolism, a blood clot. Even obstruction of the veins trying to drain blood away from the limb can cause blood to back up, slow down, and lead to peripheral cyanosis.
Okay, so cold blockages, poor pump function, all leading to sluggish flow in the extremities. Now, the source mentioned something really specific and interesting called differential cyanosis. What's unique about that scenario?
Ah, yes, differential cyanosis. It's a very specific and quite visually striking condition. You typically see it with one particularly heart problem, a reversed shunting patent ductus arteriosus, or PDA.
Okay, we talked about reversed shunting before with Eisenmengers. How does it cause this differential look?
Right. Remember, the PDA is a connection between the aorta, the main artery leaving the left heart, and the pulmonary artery going to the lungs. When the shunt reverses due to high lung pressure, deoxygenated blood flows from the pulmonary artery into the aorta. But way it enters the aorta is key. It usually enters after the arteries branching off to supply the head, neck, and front limbs have already left the aorta.
Ah, so the top part of the body gets blood before the deoxygenated blood mixes in.
Exactly. The head, neck, maybe the front paws or arms receive normally oxygenated blood coming straight from the left ventricle, but the rest of the aorta, supplying the trunk and hind limbs, receives this mixture of oxygenated and deoxygenated blood.
So the head and front look pink, but the back end looks blue.
That's precisely it. You get a noticeable color difference, normal mucous membranes in the mouth, but bluish skin or nail beds in the lower body or hind limbs. It's a really powerful clinical sign pointing specifically towards that reversed PDA.
Wow, it's a really clear and dramatic illustration of how blood flow patterns can create such specific signs. Amazing. So, okay, we've covered the main types and that interesting variation. Broadly speaking, what parts of the body are most affected by each type?
Well, with central cyanosis, because it reflects that systemic issue, low arterial oxygen or bad hemoglobin, essentially all organ systems can potentially be affected by the reduced oxygen delivery. Brain, heart, kidneys, everything.
It's a global problem.
Yeah. Whereas peripheral cyanosis, because it's about localized poor blood flow, primarily impacts the tissues in that specific area. You might see effects on the neuromuscular function of the affected limb, like weakness or pain, due to that localized oxygen deprivation.
That makes perfect sense. Body-wide issue, body-wide consequences,
Yeah.
local circulatory problem, local effects. Now, the source also touched on signalment, basically, who might be more prone to certain conditions that lead to cyanosis. Were there any particularly notable patterns mentioned, especially thinking about veterinary medicine context?
Yes, definitely. We briefly touched on the breed predispositions for some of the congenital heart defects leading to shunts and Eisenmengers like Keeshondan, bulldogs, beagles, certain cats.
Right.
But beyond the heart, the source also highlighted respiratory issues common in certain breeds. For instance, tracheal collapse is a big one in young to middle-aged small breed dogs, think Pomeranians, Yorkies, poodles. That can definitely cause airway obstruction and cyanosis.
Ah, the honk and cough dogs.
Exactly. Then there's laryngeal paralysis. There's a congenital form seen in young dogs of specific breeds like Dalmatians and Huskies, and an acquired form common in older, larger breed dogs like retrievers. Both obstruct the airway.
Okay.
English bulldogs often have hypoplastic trachea, meaning an underdeveloped, narrow windpipe from birth. And of course, brachycephalic airway syndrome, the complex of issues seen in short-nosed breeds like bulldogs, pugs, Pekingese, and Persian or Himalayan cats, is a major cause of respiratory distress and potential cyanosis.
So genetics and breed conformation definitely play a big role in predisposition to some of these underlying causes.
Absolutely. And things like feline asthma, especially common in Siamese cats, were also mentioned as a potential respiratory cause.
Good to keep those predispositions in mind. Now, switching to what someone might actually observe, the signs that cyanosis is present or that there's an underlying issue causing it, what should we, or maybe pet owners, be looking for? What are the historical findings?
Well, the signs can really vary depending on whether it's central or peripheral, and of course the specific cause. But some general historical clues, things you might notice over time or leading up to seeing the blue color for central cyanosis, could include noisy breathing. Sometimes a high-pitched wishing sound called stridor, especially on inspiration,
Okay.
obvious difficulty breathing, or increased respiratory effort. A persistent cough is common with many lung and airway issues, sometimes even a change in voice or bark if the larynx is involved.
Hmm.
Episodes of weakness, collapsing, or fainting syncope can also happen, especially with exertion if oxygen delivery is compromised. And crucially, if methemoglobinemia is suspected, a history of recent exposure to those medications and chemicals we talked about is a vital piece of information.
Right, asking about Tylenol or other potential toxins. What about signs related more to peripheral cyanosis?
For peripheral, the history might be more about the limb itself, noticing weakness, limping, or even paralysis in a specific leg. Maybe the pet seems painful in that limb.
Okay, so breathing changes, weakness, potential exposures for central, limb-specific issues for peripheral. Now, what about what a vet or doctor might find during a physical examination? What are the key physical clues?
On exam, a healthcare provider will be listening very carefully to the heart and lungs. They might hear heart murmurs, which could indicate valve disease or congenital defects. Sometimes a split-second heart sound can suggest high pressure in the lungs, pulmonary hypertension.
Okay.
Listening to the lungs, they might hear crackles, sometimes called rales, which can suggest fluid in the air sacs, like with pneumonia or heart failure, or wheezes, indicating narrowed airways, like in asthma or bronchitis. Muffled or quiet heart and lung sounds could suggest fluid or air building up around the lungs, in the pleural space, restricting expansion. If there's an upper airway problem, like laryngeal paralysis, that audible stridor might be very obvious.
Right.
With tracheal collapse, gently palpating the windpipe in the neck might trigger that characteristic honking cough. They'll also assess the pattern of breathing. Is the difficulty mostly when breathing in, inspiratory dyspnea, breathing out, expiratory dyspnea, or both? That can give clues to where the problem is.
Lots of information just from listening and observing breathing. What about examining the limbs in suspected peripheral cyanosis?
Yes, in peripheral cyanosis, the affected limb or extremity won't just be bluish. It might also feel noticeably cold to the touch compared to other limbs. It could look pale initially before turning blue. It might be painful when handled. Sometimes it can be swollen. And crucially, the pulse in the artery supplying that limb might be weak or completely absent.
Ah, checking the pulse is key there.
Definitely. And other general signs, generalized weakness can be seen with severe heart disease. Those episodes of weakness or collapse might be triggered specifically by exercise or excitement in animals with underlying heart or respiratory conditions. And in a very specific dramatic scenario, like an aortic thromboembolism, a saddle thrombus in cats, you might see sudden paralysis of the hind legs with cold limbs and absolutely no femoral pulses.
That's a really comprehensive set of signs. It really underscores that cyanosis, while a sign itself, is often accompanied by many other clues pointing towards the underlying cause. So let's try to organize those causes systematically. The source broke them down by body system, which seems helpful, starting with the respiratory system again, since breathing is so central.
Right. So within the respiratory system, we can think top down. Problems in the larynx, the voice box area, paralysis, either congenital or acquired later in life, collapse of the structures, severe spasm, swelling from infection or allergy or injury, tumors growing there, or just inflammation. Anything blocking that entrance.
Okay, larynx covered. Moving down.
Next is the trachea, the windpipe. Again, collapse is a big one, especially in those small dogs. Tumors can grow inside or compress it. Foreign objects can get inhaled and stuck. Trauma can injure it. And that congenital underdevelopment, hypoplasia, we mentioned in bulldogs.
So blockages or structural failures in the main airway. What about deeper down, the lower airways and the lung tissue itself?
A huge range of possibilities here. All sorts of pneumonia, bacterial, viral, fungal, aspiration pneumonia from inhaling stomach contents. Chronic bronchitis, feline asthma, inflammatory conditions narrowing the small airways. Bronchiectasis, where airways become abnormally widened and damaged. Lung tumors, primary or metastatic. Inhaled foreign bodies that make it down low. Lung parasites, direct lung damage like contusions or hemorrhage from trauma, non-cardiogenic pulmonary edema, fluid in the lungs not caused by heart failure, maybe from things like smoke inhalation or near drowning. Basically anything filling the air sacs or obstructing the small airways.
Yeah, that is a significant list just for the lungs and lower airways. What about the space around the lungs, the pleural space? How can problems there cause cyanosis?
Good point. If the pleural space fills up with something, it prevents the lungs from expanding fully when the animal tries to breathe. So if air gets trapped there, that's a pneumothorax.
Collapsed lung.
Right. Or if infection leads to pus building up, that's pyothorax. Or lymphatic fluid, chylothorax. Or blood, hemothorax. Tumors can grow in the pleural space. Hernias can allow abdominal organs into the chest cavity. Any of these can compress the lungs and severely impair ventilation.
So it's not just the lungs, but the space they need to move in, and the chest wall itself.
Yes. Issues with the chest wall or the diaphragm muscle are important too. Birth defects like diaphragmatic hernias, trauma-causing hernias or flail chest from multiple rib fractures, even neuromuscular diseases affecting the muscles of respiration, weakening the breathing effort. If the bellows don't work, the lungs can't fill.
Okay, that covers the respiratory system pretty thoroughly. Now, shifting to the cardiovascular system, we've already hit on congenital heart defects quite a bit.
Yes, definitely a major category for central cyanosis. Those right-to-left shunts, Eisenmenger physiology with PDA, VSD, ASD reversals, tetralogy of Fallot, Rarer, complex defects like truncus arteriosus or transposition of the great vessels all result in deoxygenated blood entering the systemic circulation.
And acquired heart disease.
Yeah.
Things developing later.
Absolutely. Severe acquired heart disease like advanced mitral valve degeneration, common in older small dogs, or dilated cardiomyopathy, DCM, seen in some large breeds, can lead to congestive heart failure. When the heart fails as a pump, fluid backs up into the lungs, cardiogenic pulmonary edema, impairing oxygen exchange and potentially causing cyanosis.
So heart failure leading to lung problems. What else in the cardiovascular realm?
Fluid building up around the heart in the pericardial sac, pericardial effusion. This can compress the heart chambers, preventing them from filling properly, reducing cardiac output, and potentially leading to signs of poor perfusion, maybe even peripheral cyanosis or shock. Blood clots traveling to the lungs, pulmonary thromboembolism, or PTE. These block blood flow through parts of the lung, causing a severe ventilation-perfusion mismatch and hypoxemia. PTE can be a complication of various other diseases like Cushing's disease, certain kidney diseases, or immune-mediated hemolytic anemia.
Right. Clots blocking the lung vessels.
And pulmonary hypertension, high blood pressure in the lung arteries. This can be a primary problem or secondary to chronic lung disease or those heart shunts we discussed. It makes it harder for the right side of the heart to pump blood through the lungs. And then for peripheral cyanosis specifically, problems with the peripheral vessels themselves. Arterial clots, like saddle thrombus in cats, often linked to underlying heart disease. Severe narrowing of small arteries. Vasoconstriction. Blocked veins preventing drainage. Or just overall low cardiac output, leading to poor peripheral perfusion and shock.
It's really striking how interconnected the heart, lungs, and blood vessels are in maintaining oxygenation. Now, what about the neuromusculoskeletal system? How can problems there lead to cyanosis? It seems less direct initially.
It might seem less direct, but the control of breathing and the muscles doing the work are critical. So, problems affecting the brainstem, where the respiratory control center is located. Things like inflammation, encephalitis, trauma, bleeding, tumors, or even certain drugs that suppress that center. They can all lead to hypoventilation, not breathing enough, and subsequent cyanosis.
Oh, if the control center isn't working, breathing falters.
Exactly. Moving down, issues with the spinal cord, especially in the neck region, can disrupt the nerve signals going to the diaphragm and chest muscles. Think trauma, swelling, slipped discs, fractures,
Okay, disrupting the signal pathway.
and then problems with the nerves themselves or the muscles they control, an overdose of paralyzing anesthetic drugs, for example. Certain toxicities like tick paralysis or botulism that cause muscle weakness or paralysis, myasthenia gravis, polyreticuloneuritis, polymyositis, various nerve and muscle diseases can all impair the ability to take effective breaths.
So even if the lungs and heart are fine, if the system driving breathing is compromised, you can still end up with cyanosis.
Absolutely, the whole chain needs to work.
And finally, we already covered methemoglobinemia pretty well, the abnormal hemoglobin issue.
Yes, both the rare inherited enzyme deficiencies, primarily noted in dogs, and the much more common acquired form from ingesting those oxidizing chemicals or drugs like acetaminophen, nitrates, nitrites, certain dyes, etc.
Right. It truly paints a picture of this intricate web of bodily functions, respiratory, cardiovascular, neurological, muscular, even biochemical at the hemoglobin level, all needing to work together for proper oxygenation. So if a vet or doctor suspects cyanosis and sees some of these signs, how do they actually pinpoint the specific cause out of that huge list? What's the diagnostic process usually involve?
Yeah, figuring out the exact cause can definitely be challenging, especially differentiating between primary heart versus primary lung problems, as they often overlap in signs. It usually requires a multi-pronged approach.
Oh.
Imaging is often key. Chest x-rays, radiographs, are usually a first step to look at the lungs, the heart size, the pleural space. An echocardiogram, an ultrasound of the heart, is crucial for evaluating heart structure and function, looking for those congenital defects or signs of heart failure or pulmonary hypertension. Sometimes more advanced imaging, like CT scans, might be needed for complex lung or airway issues.
So getting a visual look inside is important. What about lab tests?
Laboratory tests are also vital. Routine blood work, a complete blood count, CBC, and chemistry panel can give clues about infection, inflammation, anemia, or organ dysfunction that might be contributing. If methemoglobinemia is suspected based on history or the appearance of the blood, a specific blood test to measure methemoglobin levels is needed. And a really important test, especially for central cyanosis, is an arterial blood gas analysis.
What does that tell you?
That directly measures the partial pressure of oxygen, PO2, and carbon dioxide, PASIQ, in arterial blood, as well as the blood pH. It gives a precise assessment of how well the lungs are oxygenating the blood and removing CO2, helping to differentiate between different causes of hypoxemia.
Okay, so combining imaging and blood analysis gives objective data. What other diagnostic tools might be used in the workup?
Pulse oximetry is a quick, non-invasive way to estimate oxygen saturation, SpO2, using a probe on the tongue or skin, though it can be less reliable in shock or with severe vasoconstriction.
Right, the little clip-on sensor.
Exactly. The physical exam itself is always critical, as we discussed, listening carefully, assessing breathing patterns. In some cases, more invasive procedures might be necessary. If an upper airway obstruction is suspected, a laryngoscopic examination, looking at the larynx directly, often under light sedation, might be done. Bronchoscopy, using a small camera scope to look down into the trachea and bronchi, allows visualization and sampling of airway fluids or biopsies. If fluid is detected in the pleural space on X-rays, a thoracocentesis, inserting a needle to drain the fluid, can be both diagnostic, analyzing the fluid, and therapeutic, relieving pressure on the lungs. The specific diagnostic path really depends heavily on the initial clinical signs and suspicions.
It sounds like a thorough investigation is often needed, like detective work, given how many potential culprits there are. And once a diagnosis is reached, what does treatment typically look like? Is there a general approach?
Well, the most crucial thing to remember is that treatment is entirely dependent on the specific underlying cause that's leading to the cyanosis. You have to treat the root problem.
Makes sense? Fix the cause, fix the sign.
Exactly. However, that being said, in almost all cases where an animal or person presents with significant cyanosis, the immediate first step, the priority, is to provide supplemental oxygen therapy.
Right, get more oxygen in however you can.
Yes, whether it's via an oxygen cage, mask, or nasal cannula. The goal is to increase the amount of oxygen available in the lungs to maximize whatever oxygen uptake is still possible. But that's supportive care, buying time while you figure out and treat the primary issue.
Okay, and then the specific treatments.
They vary hugely. For example, if the cause is cardiogenic pulmonary edema from heart failure, treatment involves diuretics to pull fluid off the lungs and drugs to support heart function. If it's bacterial pneumonia, antibiotics are needed. If it's tracheal collapse, medications to reduce coughing and inflammation, or sometimes surgery might be considered. If it's that acetaminophen-induced methemoglobinemia, the specific antidote, N-acetylcysteine, NAC, is critical.
Right.
If it's a foreign body, it needs to be removed, often via endoscopy. If it's a pneumothorax, the air needs to be drained. It's really tailored therapy.
Got it. Address the immediate oxygen need, then target the specific diagnosis. Are there things to avoid?
Yes. Importantly, any medications that could potentially depress respiration, like certain sedatives or opioids, should generally be used with extreme caution or avoided altogether in patients who are already struggling to oxygenate.
Good point. Don't make the breathing worse. And after treatment starts, what about follow-up? What's important to monitor?
Careful monitoring is absolutely essential. You need to track the patient's respiratory rate and effort very closely. Are they breathing easier? Is the rate coming down? And of course, monitor the color of their mucous membranes, gums. Ideally, that bluish discoloration should resolve as their oxygen levels improve with treatment.
Watching for the pink to come back.
Exactly. Repeat pulse oximetry readings can help track oxygen saturation trends. In some cases, repeat arterial blood gas analysis might be needed to confirm improvement. It's also vital to educate the owner or caregiver on what signs to watch for at home, any return of the bluish color, increased breathing effort, coughing, weakness, and when to seek further medical attention immediately if things worsen again. Because cyanosis is often a sign of a serious underlying condition that might require ongoing management or could potentially recur.
Absolutely. Vigilance is key. So just to wrap up our deep dive here, the big picture on cyanosis is that this bluish discoloration is really a key visual indicator. It tells us there's either insufficient oxygen getting into the blood or circulating effectively, or there's a problem with the blood's ability to carry that oxygen, like with methemoglobin.
That's a great summary. And we learned it can manifest as central cyanosis, affecting the whole body, pointing usually to lung, heart, or hemoglobin issues, or as peripheral cyanosis, localized to the extremities, typically indicating poor blood flow to that specific area.
And the list of potential underlying causes is surprisingly broad, isn't it?
Yeah.
Ranging across the respiratory system, the cardiovascular system, neurological problems, even certain toxins or drugs.
It really is. And for you, the learner, hopefully grasping this concept of cyanosis offers a really valuable window into understanding the fundamental processes of oxygen delivery in the body and seeing the multitude of ways this absolutely vital function can be disrupted. That sheer variety of causes really underscores the interconnectedness of all our bodily systems.
It truly does. It makes you step back and appreciate how seemingly diverse situations act you.
Yeah.
I mean, everything from being at high altitude to taking too much acetaminophen to having a tiny hole in your heart from birth can all potentially converge on this single visible sign of cyanosis. What does that really tell us about the body's incredibly delicate equilibrium? And maybe the critical importance of recognizing even subtle changes like this? It's definitely something to ponder, perhaps explore further on your own.